Let's just get this on slide view. Right, welcome everybody. This is a session on an introduction for costing. My name's Scott Hodgson. I'm the head, it said head of costing there, but I've actually got a bit fancier title now. It's head of clinical accounting and costing transformation. And during this session, I'll take you through what costing is. So we'll start with the basics around what is costing, how is costing, what is it used for within the NHS, why do we need it, and then we'll go into some case studies around how we're actually using it at Nottingham University hospitals to transform some of our services and working with clinicians to help do that. As we go through the slides, Megan's waiting in the wings looking for anybody with hands up. By all means, put hands up and Megan can interrupt me or just shout up. I'd rather take questions as we go through them. There will be time at the end, but otherwise it will just be me talking to you for about, I think I've got slides for about 35, 40 minutes, and then time for questions at the end if anybody wants to ask anything. So I say I work at Nottingham University Hospitals. That's a large teaching hospital, major trauma centre, and we've been doing patient level costing for since about 2010, and we've developed that over the last 12 years into a product that we run monthly, produce the figures monthly, and use with our so clinicians have got dashboards that sit on desktops, so they can access the patient level data every month, and it's refreshed, so they can look at their own data and use that information with their services to look at pathways and how patients travel through the hospital. So I'll go on to that towards the end of the slide. So what is NHS costing? So officially, it's the quantification of financial terms of the value of resources consumed in carrying out a particular activity or producing a certain unit of output. So that's the sort of techie official what is costing. It's not the same as income. So I get working with some clinicians in Nottingham fairly recently, and people still get confused that income is the same, that they assume that tariff that we get is the same as cost. The two are completely different. If you think about your own personal finances, we've all got expenditure, utility bills, cost of living, all that sort of stuff. That is completely different to the income that we receive, and that is the same for the NHS. Although we're a not-for-profit organisation, if income was the same as cost, then there wouldn't be trusts with huge deficits at the moment. So this is about understanding the costing bit. Costing is used to inform income, and I'll go through that in the next few slides. So essentially, costing is the way we work out how much the healthcare services we provide cost. So if you think about a patient into a hospital, it's what resources are consumed by those patients as they go through the hospital up until discharge, and that includes overheads, heating, lighting, energy costs, all that sort of thing. Why do we cost? So basically, these are, you see all the time in the news around looking at, well, more recently the COVID situation. What impact does something like a pandemic have on the costs? We're obviously funded by taxpayers, so we have to look at spending that money wisely in the most efficient and ineffective way. We've got things like rising costs of medicine, so we look at how providing healthcare has changed over the years. We look at benchmarking between organisations to look at whether something that we do in Nottingham is done differently in, say, Leeds or Oxford or Cambridge, and why is that? And we're looking for things like unwarranted variation. and many of you have heard of the GIRFT project, Get It Right First Time, which is all about looking at standardizing a lot of basically best practice, certain procedures, certain pathways, and how we can standardize that across the country, rather than having massive variation depending on the organisation that it's carried out in. Obviously, there's, again, the press get a lot of this information, so we all do an annual return. Every trust is mandated to do an annual return on its costs, and that's where then you get things like, the NHS is spending X amount on, say, maternity services, or the cost of a certain procedure has gone up by 10 times, or cancer weights and all that sort of stuff. The cost of of not doing stuff, the cost of the pandemic, that all comes from these national returns that every finance department, NHS finance department, is mandated to deliver every July. And the final bit is the national cost collection, which I've just talked about. That informs tariff. So those costs that we all send in, they are used then to build tariff, and that's how organisations get paid. So that process used to be called reference costs. So reference costs are the average unit cost of the NHS providing secondary healthcare to NHS patients. It's been collected every year since 1997. Like I say, it's a mandatory collection. It's collected at something called a healthcare resource group level for acute trusts. So HRG is basically a collection of diagnosis or procedure codes that have similar levels of resources. So, for example, there'll be an HRG for a knee operation, and that will have maybe 5 or 6 different knee procedures that all use the similar level of resources, and they all sort of get grouped together into this sort of code, which is like an algorithm. And the way trusts get paid is based on that HRG. So there'll be a tariff against every single HRG. There's an index that's provided, and that's a measure of the relative efficiency of providers. So every trust, when they submit their costs, about 3 months after that, NHSE collect all those costs and then look at the activity levels that the trust has provided, and will give the trust an index where 100 is the national average, and anything over or above that 100 is a measure of the efficiency. So the last index that we got was 97, which basically means that our costs are about 3% lower than the national average in Nottingham University hospitals. If you get an index of 110, obviously you're 10% higher than the national average. And you can drill down, that's a trust level one. You can look at those index by specialty. So you could look at, say, I don't know, cardiology. So even though our trust is 97, we've got some specialties that are well above the 100 mark, and we've got some that are below the 100 mark. And these are based on national average. So obviously you're going to have some winners and losers. But this is the sort of stuff that all goes into the model hospital, and that's how you, if you've ever seen the model hospital or used the model hospital, that's where you get the opportunity figures from. Anything that's sort of over 100, there is an opportunity to bring it down to 100 to the national average. And that national average cost at HRG level is used as a basis for tariff. So basically, take that knee operation HRG. Every trust that provides knee surgery across the country will be sending the prices in and their activity levels. And you may well get some trusts that say, I don't know, and I'll plug them figures out, providing costs at £7,000. There'll be other trusts that are saying it's £3,000 because of different lengths of stay and different practices. the national average may come in at, say, 5,500. 5,500 is what the tariff then would be for that knee operation. That means the trusts that are providing the service that costs £7,000 are going to lose £1,500 every time a knee operation's done, and the trusts that are doing it for £3,000 are going to make money every time a knee operation is done. And that's where you get winners and losers all the way through the tariff. Now, obviously, over the last couple of years, because of COVID, there's been an increase in those unit costs because we're doing less activity and a lot of our costs are fixed. So there's been a change in tariff where we've had sort of a block contract to stabilise the income that trusts get during the COVID period. But from April 23, we're going to be reverting back towards a HRG based tariff again. There'll be some blocks in place, but it'll be a bit of a hybrid. So there's still a big and certainly for efficiency and benchmarking, this cost collection at HRG level is still very important. Probably less so for tariff, but it does inform the tariff and it does inform the block contracts that we've got as well. So this has all been replaced by something called the National Cost Collection, and PLICS is patient level information and costing systems. So basically it's more granular rather than this HRG level, which still exists and is still used to benchmark. We now have got the data below that group level, so we can look at variation within, say, knee operations and go, you know, at Nottingham we've done 1,000 knee operations, but there's huge variation between clinicians or between services or between wards, and why is that? So where we are at the present, we use something called PLICS, which is patient level information costing systems, and then you may well have heard of service line reporting, which is a higher level view at usually at your specialty level or clinical service group level, depending on what your organisation calls them. So patient level costs are calculated by tracing the resources used by a patient and using activity information alongside the costs. So we basically provide a cost for each event that happens to a patient. Costing at that level allows much more detailed analysis of costs and income. And as I said earlier, we can then look at profitability and contribution within the trust, even for a patient. The system allows users to assess the profitability at a range of levels as well. Because you've got it granular, we can build it up to either consultant level or HRG level or procedure code level or specialty level. And I'll show some of that at the end when I've got some of the slides showing what we're doing at Nottingham with our PLICS system. So advantages of PLICS are it combines cost and activity, it highlights clinical variation. You can join bits together because we've got the NHS number, so you can look at a full pathway. It's included in coding and counting process, which is basically the discussions that trusts have with commissioners about providing funding for services. And we look at profitability analysis, so trying to make some of our services sustainable and at least working with the tariff rather than falling below the tariff. So how does that differ to traditional finance reporting, service line reporting? So the table on the left is traditional financial management, where we've got our clinical services down the left-hand side, and we've got the cost, income, and a variance. With service line reporting, what we do is pull in the so we reallocate the costs of our corporate and facilities. So overheads basically are absorbed into the clinical services, and what you're left with on the table on the right is just a bit in a central fund for the research, costs, but even all of the other costs have increased because the corporate and facilities, which was 123 million, has now disappeared and has been absorbed into CHUGS, ESM, MSS, women and children's, etc. So that is an allocation. The bottom line is still the same, still 750 million and 697 million of income, but the overheads have been absorbed into the services that provide the patient-facing services. That then allows those services to look at whether we can look at whether they're a profitable service or a loss-making service, and whether that's direct costs, indirect cost, or overheads that is causing that. Two key differences between SLR and financial management. SLR is not looking at budgets, it's all based on actuals. And SLR allocates the cost from support and corporate areas into the clinical service lines. Traditional financial management identifies direct costs of a service, reflecting its accountability and span of control. So we still use budget reports. If you're a manager of a ward, you still need to know what your establishment is, and you need to, budget reports are essential for financial control. They help us keep within our budgets. However, the service line reporting is the true picture of how much it actually costs to run those services. So it clarifies, as I've said at the bottom, clarifies the relationship with other support areas. So the indirect costs that are crucial in delivering the activity for the patient. So, for example, radiology and pathology and theatres. So those services are now pulled into the main patient-facing patient-facing services. So we can see what the full cost of a service is. How do we do it? So we take patient activity and the ledger costs. So that will be from our PAS system. We get things like consultant episodes, all the outpatient attendances, all the A&E attenders. So that is so we run PLICS monthly. Some organisations do it quarterly, and some organisations do it annually. But all trusts now are mandated to provide PLICS data to NHSI at least annually. So annually is probably the longest that it would be. We get a monthly feed, and that list there isn't exhaustive at all, because our feeds, we've got about 30. So it's not just consultant episodes, outpatients, A&E, renal and ledger, where we get things like, we obviously get pathology, radiology, etc. And lots of other support services, well, not support services, lots of other like radiotherapy, for example, which isn't on that list, and chemotherapy. So basically patient activity and ledger costs. So we pull in the general ledger. We then pull in all the cost drivers. So that will be things like ward stays, theatre minutes, pathology tests, exam tests, pharmacy issues, the therapy contacts, high cost devices. And that is matched to the PAS system. So we're able to go, patient A came in on this day. We're able to look at the ward stays and identify which ward they were on. We're able to look at the theatre file and identify whether they actually went to theatre, and if they did, how long they were in theatre, what theatre it was. Did they go to the recovery after theatre? Did they have any anaesthetic? And what type of anaesthetic was it? What drugs were issued? Any pathology tests? So that's all done in the costing system. And what we're able to do is provide an itemised bill that says this patient was in for, say, 10 days. These are all the things that happened to him during that 10 days. We can match the patient income that came through for that patient. We can match all the supporting activity data, for example, like say theatre minutes or how many tests, and that can be aggregated then to show the position at various levels. So we can look at when we do things to patients, for example, how quickly do we get patients to theatre? Are we getting them to theatre at day 0, or have they been in the organisation for 2 or 3 days before we get them to theatre? And then how long were they in theatre for that procedure? And is that the norm, or was there a problem? So we're able to look at that, use this information, very granular information, and compare that to other specialties within our own organisation, or the consultants were within our own organisation, or externally as well. So what can it show? Here's some example data. I'll share these slides, by the way, or Megan will share them when I've finished. But here's some example data from our system that basically is showing, top left is the HRG and an HRG description. It shows activity levels for the HRG. It shows actual length of average length of stay for that HRG, what our total cost is, what our total income is, and whether there's a profit or loss for that particular HRG. And bearing in mind, HRG is a group of procedures. So on that top one, you've got very major hip procedures with a complication score of 3 to 5. And then your next one down is very major hip procedures with a complication score of 6 to 8. So this is looking at just one specialty, trauma and orthopedics, and then looking at some of the HRGs that they perform within that. Top right is a graph then that shows that profit or loss that we've got by consultant within the organisation. And then bottom right is showing something like the profit or loss by point of delivery, so inpatients or outpatients. And what we're able to do is drill into this. So you could drill into inpatients and then just focus on inpatients, and it will show you whether it's day case elective, non-elective, and you could then drill into non-elective. And all of these graphs are interactive, so they will change as you drill through. Some more example data showing average cost, average income, and average margin by consultant for a particular HRG. So this is like drilling right into a particular procedure and looking at average cost by consultant, and then we can go, well, why do some consultants seem to have a higher average cost than others when these have all got the same complication score? So it's not like you could say, oh well, Mr. X only does the complex stuff. These are all similar scored patients because they've gone through the algorithm, and the algorithm says that they've got a complication score of 3 to 5. So these are all similar types of patients, but have got very different costs and very different income. Well, similar income, but the income will depend on things like length of stay and extra payments that we might get for things like high cost drugs, for example, or high cost devices. But you can see there's a big cost. The biggest variation is cost, not the income. We then can look at, well, what's driving that cost? So for that particular procedure, the biggest driver was theatres, and the major thing with theatres is time in theatre. So we could see again by consultant what the average theatre cost was, and then we can look at, well, why is that? Does there need to be a training issue? Is it certain theatres that, and we're able to look at what theatre the patients were going through. So all the time we're able to look at what the granular data is showing us and try and pick up patterns and work with the service to go, well, can we standardise any of this? Is it a training issue? Is it an equipment issue? And then, yeah, this is a trauma and orthopedic. So this is this is one of the Nottingham our patient bill. So what we've got here is a patient that was in for 11 days. And you can see the 11 days across the bottom. Each bar graph is a day. And basically, this is showing what we do to a patient on each day. So this patient, the big brown colour on day 3 is the theatre. So when we were looking at this, we'd have gone, why did we take 3 days to get the patient to theatre? Why were they not in theatre on day 0, which was a Monday? They went to theatre on a Wednesday. The green bits are the cost of a ward, which differs depending on what ward they are on. So from critical care, the green bit would be quite high. You've got a dark green, which is the radiology test. So there was a radiology test performed on the opening day, and there was the orange, the salmony coloured bit is medical pay on ward rounds, which happens every day. And we use this with clinicians to look at when we do stuff with patients, and are we doing diagnostic testing early? What day of the week are they discharged? So this patient looks like they were discharged on a Monday. Could we have got them out earlier? Could we have got them out on the Thursday? Because it even looks like on the Friday there was just some ward, and then on the Monday they were discharged. So we look at these sorts of things and go, how could we have got that patient out quicker? You've got all the information at the top that says this was a fractured neck of femur patient. Patient was 80, non-elective. HRG was very major hip procedure with a complication score 3 to 5. It shows the episode start and episode end date. There are very, very detailed data that we can then build up to look at, things at either consultant level, specialty level, or just procedure code level. So the challenges: understanding the services, the availability of appropriate data. When we work with any service at Nottingham, we always do a session, a bit of a kick-off session that basically shows the limitations of some of the data. We've got access to shed loads of data in the NHS, but it's not all of high quality. But as finance professionals, we're not clinicians, so we don't know what's good and what's bad. We need clinicians to use that and work with us to improve it. We know at Nottingham, for example, we have a big issue, and I think nationally there's a big issue around tagging patients to the right consultant and even maybe the right specialty. So the first thing we do is show the activity data without the cost and go, this is what's showing against you as a clinician. These are classed as your patients. We can then start feeding in some of the costs to show how we've costed some of the events that have happened to those patients, but they're usually pretty good. It's the sort of, is the patient in the right area, and we have a big sort of education thing around making sure that wards pick the right treatment function code, specialty code, or the right consultant for the right patient. So when a patient's moved onto another consultant, that's actually tagged in our PAS system. Clinical engagement's key. That's why PLICS is really useful for getting clinicians engaged in finance, because it does actually put the patient in there. They can relate to the financial figures when they see the NHS number or the medical record number that we've got, because that means they can go back to the system and look and go, yes, I do remember that patient. And yeah, we didn't get them to theatre on day 0 because they were bumped because major trauma took the theatre time, for example. So we can talk about real things that happen in the hospital rather than a budget report, which is like showing, yes, I'm overspent, but I don't really know why. This actually shows where that variance is coming from. The benefits of PLICS. So it's an aid to understanding economic drivers. It's a transparency of income and costs, so you can see why we get certain income. It helps with things like clinical coding, which is down at the bottom there, because it shows, like in that example earlier, that it was a trauma and orthopedic patient with the complication score of 3 to 5. We have quite a lot of cases where the clinicians will go, we only see complex patients, and we can show the coding and go, well, actually the data's not telling us that. The data is saying that there's all these without complications and comorbidities. Does that mean there's a clinical coding issue? Benchmarking, so we use it a lot for benchmarking internally and externally. It identifies differences in practice, again, internally and externally. We can look at things like length of stay and whether that's different, or whether certain consultants are sending patients for a CT scan versus an MRI scan versus any other scan for the same procedure. Whether certain theatres are being used, or types of setting, whether it's a day case or an outpatient procedure. It informs future classification for grouping of patients. So the HRG structure and the NHS payment structure is always evolving, and this annual return that we do helps that. It informs all of that and the tariff setting. And we use it at Nottingham for business case development. So whenever we're putting a business case together for expanding a service or reducing a service, the PLICS information is used in that to either show the reduction in cost or the increase in cost based on existing practice. And again, maybe even things like what impact will expanding a trauma and orthopedic service have on things like therapies and radiology and pathology, so we can use PLICS to model. Does it really make a difference? I'm not going to read all these out. There's 7 organisations that have given me a paragraph of things that they've done with the PLICS system and working with the clinicians to save and improve services. So that's a resounding yes. It is making a difference. Having clinicians involved in finance and working with finance teams to improve services. So the last few slides for the next, say, 10 minutes are I'm just going to go through some of the reports. So at Nottingham, we've got a programme that we run continuously, where we work with clinicians and our specialties to say, part of my title is costing transformation. So it's helping to transform services, and what we do is build bespoke reports. So all of these reports are slightly different. They're all coming from our PLICS system, so it just sort of shows you the difference that you can get, different level of reporting you can get. We don't have one size fits all. So audiology, for example, this slide that's up on the screen that looks like something from the 70s, like spirograph. Each individual block going from left to right are clinic codes, a list of clinic codes. So there's a dark blue line on the left hand side which says something like U27DY. So this urology basically said that they got a fairly simple pathway, which this definitely isn't, and that was that a patient should come in for an assessment, a hearing assessment, and then following that hearing assessment, they should go to a fitting clinic, a DWAX clinic, or they don't need to come back. So there was basically 3 routes that they were expecting to see after that first block on the left hand side. Now the fitting clinic, so this is a Sankey diagram. One thing to note, there's no costs on here whatsoever. So although this is a costing system, this was just helping audiology understand their own pathway. So you can see the light blue block on the second row is the fitting clinic. So you've got pretty much half of the patients that have an assessment go on and have a fitting clinic. You've then got an orange block, next one down, which is no attendance. So they'll be the patients that don't need, after their assessment, don't need to come back. And then you've got a green block a bit further down, which is the DW clinic, which is the DWAX clinic. And again, there was a fair chunk of patients. So you've got the three biggest chunks with the three pathways that audiology were expecting to see. But then we've got probably 30 other clinics that patients were going to. And audiology didn't realise that the numbers of patients that were going to all these other clinics. And the feedback they gave us straight away was, that's just inefficiency. They shouldn't be going there. And then you can see, following the fitting, what should have happened then is that patients have an assessment every year, which is the green block, which happens quite a bit, but not a lot. And there was a huge amount of patients that were then not attending once they'd had a fitting. And following a DWAX, what should happen is they go for a fitting, but there was loads of patients going many different ways, and you can see then it's like a spider's web. By the time, the further you go right, the more separated all the patients get. So what this, and that was over an 18-month period, that diagram. So what the discovery of this was with the service was, there's multiple patient pathways. There's shed loads of lost patients within the service. And the interaction with ENT was not efficient, specifically in the paediatric gluea situation, where patients were being passed from audiology to ENT and back to audiology and then back to ENT. So some of the solutions that we've worked up with the service are to work on a primary care model, so putting audiologists into primary care, so they don't have to come into our Rope Walk House site, which is right in the centre of town. Optimisation of best practice pathways and new nationally commissioned services. Improved systems and processes, so now we've started online ordering of spare parts, so patients no longer have to come into clinic to a clinic to have to get spare parts. Patient-initiated follow-ups to stop the number of lost patients and DNAs, and skill mix improvements, which basically mean that the clinics that we are running provide more services than they were, and patients are not being passed around and going to different sort of, we've got lots of clinics that were seeing, I don't know, 2 or 3 patients, and actually that could have been wrapped up into one clinic, which was the assessment. So that's where we've worked at now, and that flow diagram is being run probably once every 3 months, just to see the impact of those changes that we're making to streamline that pathway. Next one is spinal surgery, so it looks completely different from the graph that I've just shown you. This does have money on it, and this was built with the spines team, who didn't want to look at their data by HRG. They wanted to look at it by surgery type, and they gave us the surgery types, and we were able to map different procedures into those surgery types with the clinicians. So they wanted to look at degen, trauma, adult deformity, pediatric deformity, and the last one is like work in progress. And then we've got filters down the right hand side, because they wanted to separate whether the patients were adults or pediatrics, and whether they'd had different types of interventions, whether they'd been into theatre or injections or diagnostic testing. And then by area, because they've got a theory, and what we work with is to bust a lot of myths or prove theories correct. And they've got theory that it was all the out of area stuff that was causing the huge cost that we'd got, because we get a lot of complex patients from out of area, and the Nottingham stuff would be okay. and we're able to prove, or well, we're able to disprove that theory actually, that the Nottingham stuff was the stuff that was very expensive. And what we do is build an issue tree. So this mirrors that graph before. So we've got the elective pathway, and then the next thing. So this is like the 5 whys that the transformation team go through. And we look at degenerative was making a loss, work in progress was making a loss, trauma, adult deformity, and peds deformity. And then we go through and go why, and we split it out. And this is basically the drill down of each level that we go to. So the discovery there was degenerative was making huge losses. Pediatric deformity was working within tariff and actually making us a bit of money, but there were huge list of cancelled ops. Waiting list was over a year for the Scoli stuff, and it was causing delay related harm. We'd got injections that were being carried out in an interventional radiology area, but spines were not utilising all of the theatres, so they could have used theatres to do the injections. And we've got poor clinical coding compared to neurology. So again, this was the spine saying we only do complex stuff, and the coding was saying, well, actually, no, there's a lot of stuff that's not complex in here. So the solutions were we've invested in nursing staff on a paediatric ward. So now the ward's got a higher skill mix, and it means that only the most severe patients can go to critical care, because there's now another area that is like high dependency that isn't quite critical care, but we can put the Scoli patients on that. That's reduced the risk from a 20 down to a 0, because we've reduced the length of stay that people are waiting. Flexible theatres to allow a shorter and extended lists. So what we realised was that a lot of spines ops take 6 hours-ish, 6-7 hours, but our theatres were basically leased out in 4-hour blocks. So 4 hours was not long enough. We had to book an 8-hour list to do a 6-hour op. So you're planning to lose 2 hours every time you do that. So we've got theatres into the conversation to try and tag other things on the back of those theatre lists. ERAS and SDEC opportunity, that's enhanced recovery after surgery and same-day emergency care. And they appointed a clinical champion for coding within the specialty. Final one, healthcare of older people. Again, very different. So what was the story there? They were interested in the patient journey. They asked us to bring frailty scores into the data. That was something we hadn't got in the data, but they told us that everybody over a certain age that came through ED was given a frailty test, and there's a frailty score of 1 to 9. So they wanted that in the data so they could look at the data in a completely different way. So we pulled that in. We found out who had that information and pulled that into the data. And that's where we get engagement, when clinicians ask us to do something and we're able to do it and pull it into the data so we can look at it in a different way. They got an hypothesis that inpatients admitted to HCOP outside of certain frailty scores didn't need to be there. The frailty score of lower than 6 didn't really need to be in HCOP. They'd have been better off somewhere else. So if they were presenting with a primary condition, for example, heart failure, then they'd be better off in cardiology. So what we did was pulled in that sort of frailty score and then started looking at the data to see if this hypothesis was true. And we've got this is the dashboard. It's got the frailty scores down the left-hand side of 1 to 9. So 1 being very fit, 9 being terminally ill. And they were basically saying all of the patients 6 to 9 probably should be on an HCOP ward, but 1 to 5 don't really need to be there, especially if they've got so certainly cardiology conditions. So we picked 4 cardiology conditions: heart failure and shock, syncope and collapse, arrhythmia, conduction disorders, and unspecified chest pain. And then we looked at the HCOP figures and the cardiology figures, and you can see just by length of stay for heart failure, it's 11 days versus 9 days. For syncope and collapse, it's 6 days versus 2 days on cardiology. For arrhythmia, it's 6 days versus 3 days, and for unspecified chest pain, it was 4 days versus 2 days. So massive reduction in length of stay if you've got the patient in the cardiology ward, a less frail patient in a cardiology ward than if they were on a HCOP ward. Not only that, but we then looked at things like readmissions and noticed that they were much lower on cardiology ward. So the solution to that was to get patients onto cardiology wards that have got lower frailty scores, and then have a cardiogeriatrician service or an InReach HCOP program to actually go out to those patients and visit them while they're on a cardiology ward. That is the end of the slideshow as I've got. We've done a lot of work with paediatrics, so they're just 3 examples, and very different examples of how we're using the PLICS data to transform some of our services. So each time we do a bespoke dashboard, we listen to what clinicians want and say, what is it that you think, where do you see waste? Well, how can we reduce waste within what annoys you? And this was one with our HCOP clinicians. It's like this really annoys us that we've got wards full of the patients that we don't think are best suited in our care. They'd be better somewhere else. Have you got the data to back it up? Any questions? Oh, we have a question. Lucy?
Yeah, I was just wondering with that last example, whether you had a particular strategy for sort of encouraging cardiology to take them off those the older patients who weren't so frail. I would imagine there'd be some pushback in that they wanted to save their beds for their other cardiology patients. Yeah, maybe not. Maybe in our trust, perhaps.
Yes, and it did. And that's why we've said we're still exploring that, because there's a negotiation, if you like, because cardiology will obviously want more ward space for that, maybe. And to be fair, HCOP probably want to lose a bit of ward space because they're sort of going, look, we've got all these patients and we don't think it's right that we're looking after all of these. They'd be better with cardiology. But there is that then discussion around, well, how do cardiology take on this extra case mix, if you like, without the ward space? So it's starting to happen, but we've now put the sort of cardiology service and the geriatric medicine service together to go, right, you're both within the same divisional leadership team, so it's up to your DLT to make it happen now, because all the figures stack up. And it's better for the patient, and that's the key thing.
And presumably then the in-reaching service from your geriatrician is also within the same service, so they can move their finances around to manage all of those options.
Exactly. That makes sense. Exactly. Yeah. And we had a very similar one with diabetes as well, because they came to us and said, are you, with the data that you've got, are you able to show us where all the patients are in the trust that have got a diabetes condition? And we went, oh yeah, easy, because it's a diagnosis code, so we can do that. And it's like just dotted all over the trust. And then they went, right, now can you show us our 3 wards and show us how many patients that we've got on our ward currently that have got diabetes? And then it was just full of general medicine patients, basically. And the diabetes service said, yeah, that's the problem, that we've got really specialist diabetes consultants looking after general medicine patients, and diabetes is all over the trust. And actually, we want to lose at least 2 of those 3 wards we've got, so I can send my clinicians out to the organisation, because we think we'd be better serving the people with diabetes all around the organisation, because we could probably reduce length of stay. So we built a business case on that and managed to get them at least to lose one ward on our QMC site. We're still working on the other ward, but all the data's there that backs it up. But then you're dead right. The hardest thing then is like persuading somebody else to take that area on, or take that, because somebody's got to serve the general medicine patients. Paul?
Sorry, thank you very much. That's been valuable. As you may have seen from the chat, I'm actually a pathology data provider. Have you done anything in your organisation with the usage and wastage of blood products by consultant and specialty? It's certainly something that's been done within Imperial, and it's reduced wastage, which is both a financial saving and ethically the right thing as well.
I don't know whether we've done it specifically on blood products, but we've done it certainly on pathology. Across blood will be included in that, definitely. But my team have been involved in doing an exercise on pathology usage, clinical variation, and we can see massive variation, huge variation. Interestingly, we did one with healthcare of older people where they basically, because of the way that we introduced something called internal trading, which was basically the service, and that comes through service line reporting, where HCOP were obviously being charged for all the pathology tests. That meant that they were encouraged to do less. And what the consultants, when they saw that graph that's got each day and what we do on each day, they basically said, oh, we can see it costs about £500 to keep somebody in a ward for a day, and yet we reckon if we did more pathology tests, we'd reduce length of stay. And some of these things you just have to go with and go, well, if you think that, we can monitor this for the next 2 months and see if you do more and it reduces length of stay and it's better for the patient, then that's the right thing to do. But if you do more and nothing happens, then it's obviously not the right thing to do. And we did that, and again we noticed that length of stays come down in that area. So we are doing work with pathology, but we have looked at wastage and unwarranted variation across consultants, not just with pathology, with also radiology as well, imaging.
No, I certainly agree with you. I just bear in mind that blood products vary between £300 and £1,000 per bag.
Yeah,
and you don't need to waste very many of those to make a big dent in your budget.
I'll mention that to my lot.
Thanks.
There's one question in the chat, Scott.
Oh, is there?
Do you share lessons learned with other trusts?
Yes. Yeah, absolutely. And we did as you'll know, Megan, because you were there, we did a session at the HFMA annual event on our program. So we've got those slides as well. If anybody wants those, we can sort of share the program that we've got at Nottingham. It's called the WAVE program. It's like working to achieve value and excellence. I had to remember it then. Yeah, happy to share lessons learned. We've been doing it for quite a long time, so we've got quite a lot of things wrong, but that's the best way to learn.
Thanks, Scott. Is there any final questions for Scott before we finish up today?
5 minutes back for everybody.
Yeah, happy days. Well, thank you very much, Scott.
That's all right.
Really helpful, and there's lots of positive comments in the chat, so hopefully everyone else found it useful.
Brilliant. And you'll share everything, will you, Megan?
Yeah.
Brilliant.
So we've recorded the session. We'll pop that up on YouTube, and we'll share out the slides with the deck from this morning as well.
Great. Thanks, everybody.
Thank you. Take care. Bye-bye.
Bye.